Good evening, everyone. Myself Keshav. I'm here to present a clinical case. My patient, Mrs. X, 26-year-old, resident of Aurangabad, Bihar, Hindu, homemaker by occupation, presented to our OPD with a chief complaint of vomiting for 2 months, pain in the upper abdomen for 1 month. Coming to history of presenting illness, she was apparently asymptomatic 2 months back, started having vomiting 1 episode every day initially, now having after every meal. It usually contains undigested food particles, which is non-bilious and does not contain any blood, non-projectile in nature, around 200 to 300 ml in amount. It usually occurs 1 to 2 hours after taking any solid meal. It usually is aggravated after taking any oral solid or liquids. She also complains of pain in the upper abdomen for 1 month, which is dull aching in nature, which is non-radiating but relieved temporarily after vomiting or in an empty stomach. Also gives the history of a rolling ball movement type in the abdomen, which she notices after taking meals around 1 to 2 hours after taking meal before the vomiting. It subsides after the vomiting. And she also complains of loss of appetite. History of weight loss is noted, but she has not measured the exact weight before and now. And she also gives history of constipation, where she used to pass stool every day. Now she is passing around every 2 to 3 days in small amount, which is normal in consistency. There is no blood or mucus in stool or black colored stool. There is no history of any jaundice, cough, chest pain or hemoptysis. There is no history of any low back ache in the long bones or no history of any headache. Coming to past history, there is no history of any acid peptic disease or previous surgery. There is no history of any consumption of any acid or alkali or any psychiatric illness. There is no any comorbidities such as diabetes mellitus, hypertension, bronchial asthma, pulmonary tuberculosis, coronary artery disease or stroke. Coming to family history, there is no history of similar complaints in the family. There is no history of any cancer in the immediate first and second degree relatives. Coming to menstrual history, she is having regular cycles with three kids. Coming to personal history, she consumes mixed diet. Her sleep is normal. Bowel and bladder habits, she has developed constipation in recent 1 month. Her bladder habits are normal. There is no other habits. Coming to treatment history, she was admitted in a local private hospital for the above symptom and underwent and she took some IV fluid support, and also she underwent some investigations. There is no any known allergy to drugs or food. To summarize my history, a 26-year-old lady presented with recurrent non-bilious vomiting containing semi-digested food particles for 2 months, along with dull aching pain in the upper abdomen for 1 month, with history of loss of appetite and unintentional loss of weight over last 1 month, with no any significant family issue. Proceeding to examination. On general physical examination, patient was examined in the presence of a female chaperone in a broad daylight. She was conscious, oriented to time, place, and person. Her performance status was ECOG 1. She was moderately built and nourished with a BMI of 22.2 kg per meter square. Her pulse rate was 64 per minute in the right radial artery with no radioradial relay. Her blood pressure was 110 by 70 in the right brachial artery in supine position. There is no pallor, icterus, cyanosis, clubbing, or edema or generalized lymphadenopathy. I have also looked for the supraclavicular lymph node and left axillary lymph node, which was not seen. There was no any signs of dehydration. Coming to local examination. Coming to abdomen, on inspection, shape of the abdomen is normal with fullness noted in the epigastric and the periumbilical region. Position of the umbilicus is central and inverted. Movement of the abdomen was normal with respiratory movement. There is no visible. There was a visible peristalsis, which was seen moving from the left upper quadrant to the right lower quadrant. Skin over the abdomen has no scars, pigmentation, or venous engorgement. There is no obvious swelling. Hernial sites were intact. On palpation, abdomen is soft with epigastric and periumbilical region fullness. There is no local rise of temperature or any tenderness with no guardility or rigidity. There is no palpable swelling. Percussion splash was noted on pinching the epigastric skin. There is no palpable any organomegaly. Original orifices were intact. Percussion, there is no shifting dullness or fluid thrill. On auscultation, normal bowel sounds were heard. On ausculto percussion was also done, where the stomach was dilated till the level of umbilicus. Per-rectal and per-vaginal examination did not yield any pelvic deposit. Rest of the systemic examination were essentially normal. To summarize my case, a 26-year-old lady with no comorbidities or any family history of malignancy presented with a vomiting, which was multiple in episodes in a day, containing undigested food particles for past 2 months, associated with loss of appetite and loss of weight, with no history of any peptic ulcer disease in the past. On examination, there are signs of gastric outlet obstruction with no signs of dehydration or distant metastasis.
Keshav, how do you demonstrate a suction splash?
Sir, succussion splash can be demonstrated in 2 methods. Sir. On palpation, we can just pinch up the epigastric area skin. If we can hear a audible sound, and there is another method where we can auscultate. We can keep the bell of the stethoscope on the epigastric region, and with 2 thumbs, we can hold the bell of the diaphragm and the rest of the fingers holding the lateral wall of the abdomen. On moving the abdomen, we can hear the sound. It is usually demonstrated when the patient consumes enough liquid before the examination, at least half an hour to 1 hour before. We can see if there is any gastric outlet obstruction, we can see the fluid filled in the.
So, if the patient has not taken anything for 1.5 hour prior, will you still be able to demonstrate succussion splash?
Sir, in a patient having gastric outlet obstruction, if there is patient has not vomited and if she has any residual food, we can demonstrate, sir. But if she has vomited or if the stomach is empty, it will be difficult to demonstrate, sir.
Okay, in a gastric outlet obstruction, when the stomach will be empty?
Sir, if there is a frank obstruction, patient may not have the clearance of the stomach content. Otherwise, it will take 3 to 4 hours for the complete stomach emptying, sir.
No, we are talking of gastric outlet obstruction.
If there is a frank obstruction, it won't pass. But if there is a partial obstruction, it will take some 8 to 10 hours, sir. There will be slow movement of fluid along.
So, in a gastric outlet obstruction, the stomach is never empty, even after the vomiting.
Yes, sir. There will be risk.
Okay.
Yes, sir.
What is the quantity patient vomits out? 300 to 500 ml.
Yes, sir. Yes, sir.
Or what is the capacity of a obstructed stomach? 2.5 to 3 liters.
Yes, sir. Chronicity, it can.
It will never be. So it will never be.
How do you elicit peristalsis if it is not seen?
Ma'am, we actually need to see the abdomen at the tangential level, standing at the foot end of the patient. Otherwise,
yeah, I mean, at that moment there is no peristalsis. So, is there any way to stimulate it?
I'm not aware, ma'am. Like we have to wait for some time. It may not be present all the time.
Ma'am, it is cold stimulation. By dropping some cold water over the abdomen, we can demonstrate the peristalsis.
Cold water, or even simply percussing
or flickering by flickering the abdomen, by touching.
Yes, so you can, if that is so strong.
Symptoms of gastric outlet obstruction with loss of appetite and loss of weight. First, I would like to keep my diagnosis as carcinoma distal stomach. Otherwise, I would also like to rule out possible benign of cause like pre-pyloric ulcer with cicatrization. Even though it's very unlikely, she doesn't have any periodicity or chronic symptoms.
So, in a patient who present with a gastric outlet obstruction with no palpable lump, what should be the level of obstruction, suspected level of obstruction?
Antropyloric region, or
where the obstruction will not be palpable.
Sir, if there is any associated mass in the distal stomach, it can be associated with the palpable mass, sir. But if it's a constricting type of growth at the antropyloric region or the pylorus level, we may not feel the palpable mass, sir. Or if there is any sometimes if there is any retropancreatic, if there is any nodal mass surrounded nodal mass, that can be a palpable epigastric mass we can palpate, or else if there is any secondary lesions like surrounding organs like carcinoma gallbladder or C8 of pancreas obstructing the gastric outlet, they can present with a palpable mass areas like pancreas,
Tell
gallbladder.
me why this is not an annular pancreas presenting with this obstructive features?
Her age, ma'am, like this
She's
was a
still
sudden,
young.
yes, ma'am, she is still young, but it was a sudden in onset, ma'am. She could have had a chronicity of symptoms or pancreatitis attack, recurrent pancreatitis attack, or there could be other possible history, or if it's causing at the D2 level, there can be bilious vomiting associated. We could have, since it is in the above D1 and above level, possibly less chance.
Why not a duodenal adenocarcinoma?
If it's at the level of D1 region, it can be a possibility, sir. But D2 or D3 patient will have a bilious vomiting associated with it, sir. So since patient is having and that D1 stomach is more common rather than a D1 growth, it could still be a possibility, but only
So
by
why is it not being considered? Patient will not have a palpable mass.
Yes, sir. It can be a possible DD, sir. I have to evaluate and
You missed out one more thing. We will not get a palpable mass with a patient with gastric outlet obstruction, no palpable mass.
Sir, in Wilkie syndrome and all, like
No, in malignancy, of stomach. Any particular condition can lead to this
sir,
kind of condition.
diffuse gastric cancer with a contracted stomach.
Yeah, that's linitis plastica can lead to this.
Yes, sir. They will have a contracted stomach without a palpable mass.
But then linetica plastica will not have a suction splash or a
Yeah, agreed.
There won't be gastric outlet. Sir, this patient actually came with a few investigation before, sir. She had a upper GI endoscopy in hand, which showed a growth in the antropyloric region, which was circumferential thickening, and biopsy was also taken. This is a picture of a repeat endoscopy which she underwent in our hospital. I also have a endoscopy video. Shall I play? Can I play? This is a video. Actually, with a moderate difficulty, the scope has been passed into the duodenum. Now they are actually coming back from the duodenum retrograde. This is the duodenal wall. Scope is being coming.
This is the stomach or the duodenum?
Ma'am, duodenum, ma'am. Duodenum, ma'am. They're coming back from the duodenum and yes, ma'am.
See, this is the pylorus, no? You
Yes, ma'am.
just passed the pylorus.
Yes, ma'am.
So where is the obstruction?
Pre-pyloric, antropyloric region, ma'am. This is the growth, ma'am. It is causing the obstruction.
So the pylorus looked very good, actually. Dr. Pandey, wouldn't you say so?
Yes, that's what I wanted to ask him. If you can pass a scope, where is the gastric outlet obstruction?
Actually, with a moderate difficulty, they were able to pass.
And the stomach is empty.
Yeah.
You are able to do you have done endoscopy twice.
Yes, sir. This patient was
just can you move the video back?
Yes, ma'am.
Slowly.
Show the pylorus.
This is the growth, ma'am.
No, growth हम लोग को दिख रहा है. तुम
pylorus दिखाओ. Pylorus दिखाओ.
It is opening. Yeah, see, just freeze.
Yes.
See,
yes,
it is completely normal. It is completely normal. Nahi, Dr. Pandey, we used to do endoscopy ourselves.
Exactly.
So I can tell you with my experience, the pylorus is normal.
There is no obstruction.
There is no obstruction, and there shouldn't be any difficulty in passing it for a skilled gastroenterologist.
Actually, it's a partial obstruction. There is no complete, but there is a obstruction which is she is able to. Actually, there is another barium study also. Barium.
Barium chodo. We are discussing this thing, no?
Sorry.
Barium, it's all right.
So
do you have that barium?
Yes, ma'am. Actually, I have.
So I actually doubt that you are able to demonstrate the succussion splash.
There was a succussion splash. We have examined in presence of all the residents. There is a succussion splash.
Stomach looks. There is a good amount of shouldering here.
See, this barium meal, I don't know why it was done. Why was it
They
done?
had, sir, actually the patient had got all this investigation outside, sir, before in hand. It was not done from our side. Patient had this investigation in hand, sir.
So it was barium meal follow through. Show me the follow through.
Sir, I don't have all the photos.
So why are you showing this picture only? Show me the follow through.
The next one.
Next one. Take the next one.
Yes.
See, the
And
contrast is going in the intestine.
it is
Sir,
going,
there is
but
a
there is
partial,
definitely there is a
yes, sir,
narrow.
there is a partial obstruction, but not a complete obstruction. But there was a chronically dilated stomach, we can appreciate that.
See, how many days between the barium and the endoscopy?
Sir, endoscopy was done on 22nd, and barium study of taken the date exactly. It was done after the before the endoscopy, sir. Actually,
कोई बात नहीं. Tell me the date. What's the time difference between the barium study and the endoscopy?
taken the note of the date, sir.
It will be there on the picture.
And show us the endoscopy report, Keshav, please.
Yes. Actually, sir, I'm not able to find the date.
It's okay. It's okay.
It's important, okay, Keshav? Why am I asking it?
Sir, before doing contrast can clog and cause the obstruction. That is one point, sir. Otherwise, endoscopy.
What will clog and cause obstruction? This barium will obstruct.
Barium paste. It can sometimes form a hard mass and cause the obstruction in the small bowel or in the duodenum.
So if there was a gastric outlet obstruction, the barium should have been inside the stomach at the time of endoscopy. If you don't find barium in the endoscopy, that means there is no obstruction.
Sir, it has been clear, sir. This was the endoscopy with the patient came. Actually, image is not very clear, but there was no any sign of any barium.
Go full screen. See, it says there is eccentric pylorus with surrounded stricture.
There was an ulcerated structure of mass. Here we can appreciate.
So it's eccentric. It's in the pyloric antrum, but it's not sitting on the pylorus. And
is there something missing in the endoscopy report?
Fundus, they have commented, sir. G junction, they have commented.
You think all the required comments are there in this report?
It's empty.
Duodenal evaluation, if they were not able to pass.
They have not written they have not been able to pass. So why are you insisting that they have not been able to pass?
They have not evaluated duodenum.
They have not evaluated.
Yes, sir. They have not evaluated.
So on the basis of this report, you cannot say there is a gastric outlet obstruction. And then later
show the other report also. Other report also.
Let's able to pass up to the duodenum. So there is no gastric outlet obstruction.
Sir, actually, when repeat endoscopy was done in our hospital, they were able to pass with a moderate difficulty. The video which I played was from our hospital.
So you show us the report that they gave.
Actually,
no, it was there. It was there.
You just showed it. You just showed it.
I saw it. Go to your desktop and see. You're able to find it out from here, and you don't know your desktop. D1, D2 is normal. They say ulcer of size.
And they don't say that there is a gastric outlet obstruction. See this?
On the greater curvature, they are saying. Scope passed with moderate difficulty. So there is no GOO. There is partial GOO. You can say.
Partial, ma'am. Yes, I agree. Partial GOO. Like patient.
And what is there in the history that is against having a GOO? What kind of a vomiting patient have when he has a GOO?
Sir, in a frank GO, patient will have a projectile vomiting, sir.
You don't have?
No, sir. There is no projectile.
Still you made a diagnosis of GOO.
Like examination, succussion splash, and auscultative percussion.
Did you ask the patient to take water before you demonstrated the succussion splash?
Yes, sir. I did do that, sir.
So that is why the suction. You drink water and take a succussion splash, you will get it. You ask some of your colleague to drink 1 liter of water and demonstrate a suction splash. It will be there because it is not going to clear immediately, no? It will take some 5-10 minutes to clear. Suction splash is never demonstrated by asking the patient to drink water. There has to be a gap of about 4 to 6 hours before you demonstrate a suction splash. So your diagnosis is wrong. It's not a gastric outlet obstruction. Yes, it is carcinoma stomach, but it is not a gastric outlet obstruction. So management is going to change.
So one sec, was the endoscopy report complete? Any particular comment which was missing?
So
which is important for your management.
They have seen the fundus, G junction, and the distal. They have seen duodenum.
They have not commented on the distensibility.
You got the endoscopy repeated.
Yes, sir.
You at that time you knew that patient has a lesion in the stomach, correct?
Yes, sir.
Did you ask them to do a EUS and staging?
US was not done, sir, since US is usually considered in a early gastric cancers in a small.
So how do you know it is not an early gastric cancer? Looking at this endoscopy picture.
US should have been added. We'll give a better T staging and surrounding.
You have a facility for EUS. Why don't you ask? You are getting endoscopy done again. Same sitting you would have done a EUS without much difficulty. Would have known your staging. Okay, so what else you did?
Sir, again, the patient had a blood investigation reports in hand, which all the parameters were essentially normal, and the albumin and the hemoglobin levels were normal. And patient also had a CT abdomen and pelvis report with the film, which was reviewed, and it again showed a growth. I have a video. It is a grossly dilated stomach. We can see, and you can see the thickening at the antropyloric region. So there is a small thickening.
So this was quite an early lesion. EUS was required, ideally, if patient was affordable.
Yes, ma'am. There is no node in CT also. There is no nodal disease. Only a small thickening noted at the distal antropyloric region.
And you had this report before in your hand, and still EUS was not done.
She came with the CT, or you got the CT done yourself?
No, she had the CT beforehand. She had all this investigation beforehand. She didn't have a CT thorax. We got a CT thorax evaluation. Otherwise, she had this CT contrast abdomen pelvis. There was no any non-regional or perigastric nodes also noted. Only a thickening in the antropyloric.
How do you pick up a malignant node versus an enlarged benign node on CT?
Ma'am, CT with the fine cuts, if it's rounded in nature more than 1 centimeter, it will characterize as a malignant node. Otherwise, it will be subcentimetric and elliptical in nature. It will be benign reactive node. Rounded and necrotic node, it's in the central necrosis. It's more towards the malignant.
What are the other features?
Necrosis.
Suppose it's an EUS. EUS you are doing an. I mean, you tell me both on ultrasound features radiologically.
Yes,
benign versus a malignant node. There are 5, 6.
Yes, ma'am. On endoscopic ultrasound, loss of halo in the center, ma'am, where we can appreciate in endoscopic ultrasound.
So what is that called? What is the shape of a normal lymph node?
It's a spherical.
Spherical, is it?
No, sorry, ma'am. It's elliptical.
Elliptical. That's also wrong. It's bean shaped.
Bean shape. Yes, ma'am. Bean shape. Bean shape.
And what that is hypoechoic thing you see in the center? What it is called? It's a fatty hilum.
Loss of fatty hilum. Loss of fatty hilum.
So that is lost, and then it becomes spherical.
Spherical, yes, ma'am. It becomes spherical.
And
on the extent on the area, it will be irregular in nature due to the malignant deposit. The nodal will have a irregular deposit.
You should read about this because there is plenty of literature on this, and there are 6, 7 points. You should be able to enumerate it 1, 2, 3, 4, 5, 6. Chalo, aage chalo. Let's come to the topic.
These were the findings, and CT thorax was done, and there was no any segment. And she also had a biopsy report in hand. Biopsy showed a finding suspicious of malignant pathology. I also had a discussion with the pathologist where the sample was very small to comment completely. So that's why we had to do a repeat endoscopy, and a repeat biopsy has been sent. So repeat biopsy is awaited, sir. These are the investigations which have been done for the patient. And if the final histopathology, if it comes malignancy.
Why do you need a biopsy on this patient? Patient, according to you, has gastric outlet obstruction. Why don't you operate upfront? Why did you repeat the biopsy?
Sir, if it comes benign and there is no
You would
invasive,
still operate. You would still operate, right?
still have a non-invasive like stenting can be an option and treat the if there is any H. pylori or if there is any other benign condition, non-operative intervention also I can consider, sir. If it's not malignancy and
When would you stent a patient? Suppose this is a peptic stricture and this is a young patient with possibly a long life ahead. Would you like to stent this patient or do some definitive surgery? So a surgery in a benign case, is it different from that of a malignancy? That's what he's trying to ask you.
ma'am, surgery for benign, I have multiple options. First, if it's due to H. pylori, I can have vagotomy added and a draining procedure. With a distal gastrectomy, I can have a Billroth 1 anastomosis. And if there is no
So does biopsy help you to decide?
yes,
That's
ma'am. Yes,
what
ma'am.
he's trying
Definitely,
to
yes, ma'am. Definitely,
ask
biopsy
you.
helps in planning my management.
Which part of the surgery changes with the biopsy?
Sir, whether I have to do the anastomosis is the one part, sir, and also the resection part. If it's a malignancy, I'll be
what anastomosis will differ? Which is the most
Bill,
important part in stomach cancer?
yes, ma'am. Resection, ma'am. Resection,
What resection?
like if I'm doing the distal resection, I'll be
Array,
doing
stomach margin is more important or the something else is more important in which there is ample literature in present.
lymphadenectomy.
So this is the most important part of the surgery for gastric
If it's a benign stricture, the only difference in surgery is the lymphadenectomy. You will not do a lymphadenectomy.
Yes, sir. Lymphadenectomy I won't be adding, and also
The draining procedures are going to be the same. If you are going to do a distal gastrectomy, you have to drain it.
yes,
You have to maintain the continuity.
I was talking about I can still go ahead with the Billroth 1, which is not recommended in malignancy. But it's not.
No, why is it not recommended? You please tell me which trial states that Billroth 1 is not recommended?
I'm not able to specifically recall. Sir.
No, there is no such contraindication to the best of my knowledge. It's actually a more physiological
continuity will be yes, ma'am. But since due to malignancy, we take enough margin and subtotal gastrectomy is
No,
done.
in this patient, if there is such a little growth, and I mean, we want to discuss later. Billroth 1 is not a contraindication as far as I know. Absolutely not.
If the biopsy comes out to be lymphoma, will you operate this patient?
Sir, I can give a systemic therapy for lymphoma and look for the improvement in the symptoms. If it improves and
you first tell us the primary gastric lymphoma, how do you diagnose it? What are the criteria for diagnosing a primary gastric lymphoma?
Ma'am, patient will have associated, usually it will be in the background of H. pylori. It can have biopsy, along with the biopsy, we'll have the IHC status to characterize the type of lymphoma.
Keshav, which layer of stomach the lymphoma originates?
It's a submucosal layer, sir. Usually, it will be in the submucosal layer. It's not a mucosal disease.
So, how does endoscopic picture of a lymphoma differs from a carcinoma?
Sir, so it will be a submucosal bulge. Sometimes it can ulcerate and cause a ulceration in the mucosa, but otherwise it will be a submucosal bulge. It usually needs a true cut. It's a core needle biopsy with a US guided is needed, not a endoscopic picture like biopsy. It's a US guided core needle biopsy recommended.
So now you are waiting for the biopsy and you have no management plan for this patient.
Yes, sir. If it comes out.
Keshav, you read the Dawson's criteria for labeling a primary gastric lymphoma. Tell me tomorrow.
Again, sir, it's a submucosal disease. It needs a US guided core needle biopsy, sir. It's a submucosal disease.
That means here there are basically two things that you should notice. That one, the patient doesn't have a GOO. Second, you kept only one diagnosis of carcinoma of stomach. You didn't keep the differentials because here there are differentials. Lymphoma is a differential, duodenal carcinoma is a differential, GIST is a differential. So all
But
those should have
actually,
been differentials.
but actually, I've
But
Googled
that will be, Dr. Pandey, pathological diagnosis, isn't it?
Carcinoma, basically, if he says carcinoma of the stomach, he is talking of epithelial tumors.
Yes, sir. Yes, sir. Just usually have a
If you have said
presentation of
gastric tumor, it would
bleeding.
have considered everything. A malignant gastric plasm.
I think that is the best way to
Because you
say
said
it, है ना?
carcinoma, that means you basically are talking of epithelial tumor. And last time I told Mainak also that try not to make a pathological diagnosis on this. Like in a breast cancer, you say it is a carcinoma of the right breast. So the moment you use the word carcinoma, you are emphasizing that it is epithelial neoplasm. So
Actually, I said,
if you are keeping the diagnosis of epithelial, you have to keep non-epithelial as differential.
but the most common presentation will be bleeding. That's why I didn't
In
just just stomach, sir. They usually present with bleeding, sir. Hematemesis or melena. That is the most
when
common.
does hematemesis or melena occurs in gist?
Sir, when tumor grows bigger and it ulcerates and bleeds into the stomach.
So at which location of the stomach the lesion will be as big so that it can ulcerate and bleed? Or what is the commonest site within the stomach where the gist arises?
Curvature, sir. Greater curvature, sir. Greater curvature of the
Curvature.
stomach.
So greater
They,
curvature is the only part of the stomach where a tumor can become big,
yes, and
can
ulcerate.
ulcerate, and can bleed. But then in that case, it will be palpable also.
Not necessarily palpable. We just did, I think, a month back, one big gist of the greater curvature of stomach. She presented with hematemesis. So suppose the repeat biopsy comes as adenocarcinoma, what would you do?
In that setting, in the recent CS stomach, this looks like a T2 lesion, ma'am. It's not a T1 lesion. Ideally, a endoscopic ultrasound would have helped me in staging the disease more better. But thinking these are the T2 lesion and there is no nodal disease, I can offer a staging laparoscopy followed by radical T2 distal subtotal gastrectomy with D2 lymph node, followed by adjuvant chemotherapy
So
based on the
what is making you think it is T2? It could be T3. How are you going to say by looking at CT scan, the picture that you have shown, that the serosa is not involved?
Sir, to be more precise, yes, definitely I would like to go back and do endoscopic ultrasound. Have a more clear T lesion picture. Sir. It's T1 or below, like.
So how your management is going to change between serosal involvement and non-serosal involvement?
Sir, I can consider a stenting and pre-op chemotherapy. I would consider, sir, rather than a upfront.
Stenting.
Yes, ma'am. There is an option of.
Is it in the guidelines? Is it in the guidelines that gastric outlet obstruction, potentially resectable disease, you will do stenting and neoadjuvant?
As I said, if it's T4, like as sir said, if it's involving the serosa, ma'am, T4 lesion, I would.
T4 is not serosa involvement. T4 is serosa involvement?
Yes, ma'am. T4A is serosal involvement.
Sub-serosa,
T4B is T3 sub-serosa, ma'am. T4 is serosal
Acha.
involvement. T4A is serosal involvement. T4B is adjacent structure involvement, ma'am.
But this you said is T2?
Yes, ma'am. Not in this case, ma'am. Not in this case. In the scenario which sir gave, if it were T4 with serosal involvement, then I would consider stenting and.
But still, I don't understand this. I mean, I don't know what other doctors think, but a potentially resectable patient with gastric outlet obstruction, pre-op stenting, I have not read.
Giving perioperative chemotherapy in T4, especially in lesions like T3, T4, it increases the R0 resectability. Like,
I agree, but I don't know. To read. Dr. Pandey, what's your opinion, Tarun?
I would do a laparoscopy first in the stomach. If it is a stomach, I'll first do a laparoscopy. And if I do not have a peritoneal disease and there is no omental disease, then I'll proceed with surgery. And what will be the surgery? It will be distal gastrectomy with
D2 lymphadenectomy.
minimum D2 lymphadenectomy. So what are the lymph nodes that you're going to take out in a D2 distal gastrectomy?
In distal gastrectomy, sir, with D2 lymphodectomy, perigastric group starting from level 1, except for the level 2, level 1, level 3, level 4, level 5, level 6, that is the perigastric group, and the level 2 group, that is 9 left gastric, common hepatic,
What do you
celiac.
mean by level?
Sorry, sir, level of that particular region.
You talk about nodal stations, levels.
Yes, sir. Yes, sir. Perigastric.
And what you said, 9, station 9 is what? What did you say?
Left gastric, ma'am. Left gastric. Sorry.
9
celiac.
is left gastric?
No, celiac, ma'am. 7 is left gastric.
So up till 7, it comes as a D1 group only.
6 is D1, ma'am. 7 to 11 is D2.
No, I think 7 comes in the revised D1 group only. It is mandatory to remove left gastric lymph nodes. Okay, and then 9, yes,
Yes, ma'am.
you should,
9
and I will also.
celiac. Yes, ma'am. 9 celiac. Splenic hilar group is not routinely removed unless it's involved. Usually it's seen in the fundus and the greater curvature tumors, ma'am. And level 11 again, if there is no involved nodes, we may exclude the level 10 and level 11. These two levels we can.
You will exclude 11 along the splenic artery in a distal gastrectomy? The whole of it?
Ma'am, if there is any palpable or significant nodes, we can remove. Otherwise, we can just go ahead with level 10. Definitely, it's not recommended unless it's.
ये कहाँ पढ़ा तुमने ये? Where did you read this? Where did you read that in a distal gastrectomy, D2 does not involve dissection of the proximal half of splenic artery?
Proximal half, yes, we can go ahead, ma'am. Actually, in the Dutch trial, ma'am, where now the 15-year follow-up has come, in initial they had added distal pancreatectomy with splenectomy, where they had a poor
No, you are totally confused. I am only asking you dissecting. See, there is something called the Japanese cancer guidelines. Have you read it? These definitions came from, there is, it's available on web. It's free. And if you see D2 distal gastrectomy, it will include 9, that is celiac, and proximal part of splenic also. Every time we do, you cannot leave splenic artery. Then what is D2 you are doing in distal? Absolutely rubbish if you say like this. You do not add a pancreaticosplenectomy anymore unless there is gross involvement of spleen or there are nodes sitting at the hilum. That is agreed, and that too in total gastrectomy.
Yes, ma'am. Japanese, they do follow that preserving even the level 10, they go ahead and remove preserving the spleen.
I am from the Japanese cancer guidelines 2018. And you should memorize this. There is no if and but here.
The only two groups that you leave is 2 and 11. Everything else goes.
11 also the distal half. The proximal part of the splenic artery has to be cleared.
Which was the trial which compared D1 and D2 gastrectomies?
Sir, there were multiple trials, sir.
The landmark trial?
It's a Dutch trial, sir. Dutch trial actually showed the survival benefit of D2 lymphodepectomy. With a 15-year follow-up, they told they gave survival benefit, a significant survival benefit with the D2 lymphodepectomy.
So these are all historic trials. There is one more along with the Dutch trial from UK.
MRC UK,
MRC trial.
But they had a poor survival with the D2 lymphodectomy in that study, actually.
Yeah, but these are very important initial trials.
Prince Wales and Italian study, which was in 1988, that was the first study. But that trial is the important.
What margins will you consider during a resection?
Sir, in a distal growth, proximal margin of 5 centimeter is recommended, sir, and a 1 centimeter distal margin is needed.
It is 5 centimeter or something else.
3 to 5 centimeter.
You have to ligate left gastric.
Yes, sir, we will be ligating left.
As it arises from the celiac trunk. Yes, so where will be the cut coming once the left gastric is ligated?
Only the 20% of the stomach where the fundus area is left behind. 80% of the distal subtotal stomach has to be removed. Normal distal subtotal gastrectomy, we just leave behind 20% of the stomach where short gastric artery or left gastroepiploic
So
artery.
in this tumor which is sitting at the pylorus, you will do a subtotal gastrectomy or you will do a distal gastrectomy, and what's the difference between the two?
Ma'am, I would still go ahead and do subtotal gastrectomy, ma'am. In a
Why?
malignant, proven malignancy, it's recommended to do a subtotal gastrectomy.
Why? Is it?
Yes, ma'am.
Which guideline are you quoting? So there is no distal gastrectomy, you mean to say, in malignancy?
It's usually in benign condition we do distal gastrectomy.
अरे नहीं भाई,
Oh, beta.
क्या है तुम
Oh.
पढ़े नहीं हो क्या?
Early gastric, actually we can do, ma'am, T1 lesion with a 3 to 5 centimeter margin. Even in a greater curvature tumor also we can go ahead and do, ma'am, but in a T2 and above, subtotal like is the recommended, ma'am. Like early gastric cancer T1 lesion, as you said, minimal like distal gastrectomy can be done, but a T2 and above, ma'am, subtotal is recommended.
In a T1 lesion, you can do endomucosal resection.
Yes, sir. T1A and in T1B with no iris features.
So where is the question of distal gastrectomy?
No, sir. In the patients who have poorly differentiated LVI PNI positive, those patients needs distal gastrectomy, sir. Not the endoscopic procedure. In those patients, there should be no LVI PNI and no nodes and well differentiated tumors. In those patients, only the submucosal dissection is recommended, and size less than 3 centimeter. In few cases, less than 5 centimeter. With iris features, we do distal gastrectomy with lymphadenectomy along.
I don't think so. If there is a good margin, actually what they say is if it's a diffuse type of tumor and infiltrating growth pattern, you can take a maximum margin of 8 centimeters. And if you're still not sure, you should confirm it by frozen section.
Frozen, ma'am.
And otherwise, if it's not a diffuse type of growth, 5 centimeter margin is good enough. And in very early T1, T2 lesions, only 2 centimeter margins are also good. So
Ideally,
the
ma'am,
thought.
actually, yes, ma'am. Yes, ma'am. Ideally, frozen is recommended if you are taking a
Not
less
ideally in all cases is not required. That's what I'm trying to drive the thought home.
actually,
And the other thing, you read those Japanese cancer guidelines. I don't know what you are reading. That should be your Bible for stomach. Nobody knows more stomach than the Japanese. And the other thing is distal gastrectomy is very much done in patients with gastric cancer. So you can't say that every patient you will end up with a subtotal or a total gastrectomy.
Even in advanced cancers.
After you will be doing them after neoadjuvant therapy, no? You are not going to operate them up front.
So why is there this discrepancy in margins? Proximal you're taking 5 to 7 or 8 centimeters, and distal you're just taking 1 or 2 centimeters.
Distally, it's the duodenum which is the margin, and in the stomach, if the growth in the stomach, it spreads submucosally in the upward direction, sir. Like in distally, there is a change in the mucosa, sir, like from the gastric and the duodenum change. So, and
is
also
it the mucosa or the muscle? Something changes?
What is the barrier? What is the barrier? Distal barrier.
Then it is the pattern of the lymphatics that determine proximally and distally the lymphatics in the stomach is different. They say.
Lymphatics will not decide your margin of excision. They will decide your extent of lymphadenectomy. He is right when he is talking of proximal that the disease may spread submucosally and 5 centimeter margin is required. Now the question here is why it does not spread distally 5 centimeters. That is what Tarun wants to know. So what stops it from going distally or beyond the pylorus? What is the barrier that stops the tumor from crossing stomach to duodenum? Alika gave you a clue, you didn't take it.
circular muscle.
Which muscle?
Circular muscle which forms a sphincter. Right.
Yeah, the circular muscles which form the sphincters act as a barrier to distal spread. And that is why 1 centimeter margin is sufficient. Most of the tumors, you will not find the tumor going into the duodenum, even if it is distal. Even the pyloric tumors which occurs on the pylorus usually do not go into the duodenum. They can go when they are very advanced, but usually early tumors will not go into the duodenum.
What is bursectomy?
Ma'am, bursectomy is the complete removal of the omentum along the peritoneal layer, ma'am. Earlier it used to be followed.
What is this statement? Complete removal of omentum over peritoneum.
All
what
the
is
four
this?
layers, ma'am. All the 4 layers, we go along. We raise the omentum from the infracolic omentum, and we go along the transverse mesocolon fascia, and we go along the planes and remove all the 4 layers of the omental layers. Ma'am. And this complete removal is called vasectomy. Earlier, it used to be the standard of care in gastrectomy, but nowadays, after now, due to the usage of laparoscopic surgeries where vasectomy are found to be very difficult, they did a study in Japan, in China. I'm not able to recall the study, ma'am. They found out that even without a vasectomy, survival is not altered. So simple omentectomy is enough. And nowadays, even in early less than beyond 3 centimeters, we can just remove. That is also like not a standard of care that we have to go ahead and.
So is it stage driven? Are there any indications when you will do a bursectomy and when you will not do a bursectomy? When will you do? Still bursectomy is required in some patients. When?
Before, if there is a serosal disease involving the omentum and involving the fascia, then we have to go ahead and remove the complete bursectomy.
So what was the complication? It was not because they were finding it difficult to do. It's not all that difficult. What is the specific complication that occurs as you strip the pancreas?
Pancreatic fistula, ma'am. They found out in going and doing the complete bursectomy, opening up the pancreatic parenchyma, pancreatic fistula was noted. That was the one major complication they did in.
And this was not resulting in any survival benefit. That's why it was abandoned, not because they are finding it difficult to do it. What are the indications of splenectomy in a patient with gastric cancer?
Yes, ma'am. In a proximal stomach cancer, like in fundus and the greater curvature, with obvious involvement of the spleen, or if there is a nodal disease, dense nodal disease in the level 10, which cannot be with the spleen preservation cannot be done. In those cases, we have to go ahead and remove the spleen, proximal tumors normally.
What are common complications of distal gastrectomy?
Sir, post-operative bleeding and anastomotic leak is another major complication, and bleeding and associated pulmonary complications are another common complication.
That is with any upper abdominal surgery. That's not specific to distal gastrectomy. I'm asking specific to distal gastrectomy.
Distal gastrectomy with based on the reconstruction, sir, if it's a Billroth 2 reconstruction, patient can have bile reflex gastritis, which is less common in Roux-en-Y anastomosis, sir. And patient in the long stage, the patient will have nutrient like vitamin B12 and iron deficiency, sir. In a long run, these are the.
And anything more specific?
Specific.
Dumping syndrome, ma'am.
Dumping syndrome, like in early.
And also the duodenal stump blowout. So what adjuvant will you consider for this patient? Suppose the histopathology comes at PT3N1 disease.
T3N1, sir. Based on the classic trial, I would like to give 6 months of KPOX, sir. Even a few Japanese trial where they have tried S1 based on SCTS GC trial, where they gave S1 drug. It's a oral drug, tegopar, gemaracil, and otaracil. It's a combination drug. In that also they found out a survival benefit, but in India we usually follow classic trial where 6 months of KPOX is recommended. It has shown a survival benefit.
What are the other options you have?
Sir, if I had followed a MAGIC protocol or FLOT 4 protocol with a perioperative therapy, then I can give ECF in MAGIC protocol where with a low performance patients, in a good performance status patients, I can consider a FLOT regimen, sir. Where docetaxel for
any other option?
Even simple CF, cisplatin and 5FE is also another. Accord 7 This is another trial where they just gave cisplatin and 5-FU, ECF, CF, and Floxer.
Is there any role of adjuvant chemoradiation?
Sir, intergroup 116 has showed adjuvant chemoradiation in margin positive disease, sir. And if there is a less than D2 dissection is done, then definitely chemoradiation adjuvant setting intergroup 116 has showed a benefit, sir. In a new adjuvant setting, there are studies which is being going on, sir, like the Top Gear trial they are looking for.
Is there any role of HIPEC?
Yes, ma'am. In adjuvant setting, in a patient with cytology positive or peritoneal disease, HIPEC is one modality we can consider, ma'am, with a low PCI score. Or even in a neoadjuvant setting, PIPEC pressure that can also be seen where that is IPEC, there is a role, ma'am. Like I'm not able to recall the trial. I'm not able to recall that, but there is a survival benefit with IPEC in CS stomach with low PCS score.
How will you replace these patients with vitamin B12 in post-operative periods and subsequently?
Sir, usually B12 deficiency is not seen in early post-operative period. It's normally seen in 3 to 6 month time. We can follow up the patient and look for the symptoms, and if there is any signs of megaloblastic anemia, we can consider if patient is a vegetarian consuming patient, then we may have to give IV supplement. Otherwise, oral B12 supplement can be given. It will be sufficient.
What other deficiency can occur other than
Sir,
B12?
Yes, sir, iron deficiency anemia is one important thing, sir.
Why will the iron deficiency occur?
Sir, due to loss of stomach and less acid secretion, the absorption of the ferrous form of iron, which is normally seen in the normal stomach, where it converts ferric to ferrous in the acid environment, it is not there. So they will have loss of iron absorption. So we have to give a ferrous supplement.
There's another reason to it. No, this is not the reason.
Sir, the absorption happens in the duodenum and the food is getting bypassed. So the absorption is less.
Common mechanism which has been told is like a ferric form of iron, which usually converts into ferrous form in the acid environment, but less stomach and less acid environment, we don't see the iron absorption proper. So we have to supplement with the ferrous sulfate form of capsule. 100 to 200 milligrams of elemental iron has to be given, sir, per day.
One of the reason is that iron gets absorbed in duodenum and early jejunum, and while doing a Roux-en-Y, we are actually bypassing the natural passage of food through that area. So that's why we need to supplement iron for these patients.
Right. Iron absorption is from the acidic medium.
Will you consider doing a feeding jejunostomy in these patients if you are fearing a leak?
If I I can start orally as early as possible and consider. Otherwise, in a total gastrectomy patients, if you are delaying, then in that particular situations, feeding jejunostomy is being done in few cases, like not a routine.
Any one more indication?
What in total gastrectomy? Excuse me. What in total gastrectomy? What you said?
Ma'am, in few cases where they do total gastrectomy with esophageal anastomosis, if they don't start early enteral feeding, in those patients, feeding jejunostomy can be considered in those patients, not in routine distal gastrectomy patients.
What is ERAS protocol in gastric cancer?
Sir, ERAS protocol, it has multiple components in gastric cancer surgery. It starts from the preoperative period, sir. Making the patient pain-free and taking the liquid diet till 2 hours before the surgery, and in intraoperative period, we have to consider the other pain modality like epidural analgesia, and in post-operative period, we allow early enteral nutrition, starting with liquids in the POD 1 or in the POD 0 itself, 3 to 4 hours after the surgery. and early mobilization, and no placement of drains or NJ tubes. If there is any NJ tubes are placed, early removal of the NJ tube, and early mobilization, and these are the major.
Now answer the Tarun's question. Would you do a feeding jejunasmy?
If you are
In
following
one particular setting, it is recommended. If you are anticipating adjuvant chemoradiation in this patient, then you should do it.
Acha, tell me, when we consider neoadjuvant therapy, should you do a laparoscopy before starting neoadjuvant?
Yes, ma'am. In any patient, if you are planning neoadjuvant therapy, we
Yeah.
have to do staging laparoscopy, and a cytology has to be done to know the status, ma'am. Before starting neoadjuvant therapy, it's a must. Neoadjuvant, we have to do staging laparoscopy with cytology.
Ideally.
Prognosis, we can know if there is a cytology positive, it is considered
Cytology positive, it is considered M1.
M1, yes, definitely.
And I'm
Yes.
seeing that the problem basically is making diagnosis and differentials. That is what everybody has to work upon.
Sir, regarding this differential diagnosis, should we consider all possible differential diagnosis and say, or should we wait for the examiner to ask us, like, why not this, and we should exclude by examination and history?
Mainak, if your whatever fits in your history and examination should be kept as differential.
So we should be saying this for I am having this 4-5 differential based on my history and the examination.
Yeah, if you have 4-5, you keep 4-5. Like the problem here is like he's putting carcinoma, then he has to put lymphoma, then he has to put JACE, then he has to put duodenal carcinoma. If he says malignant neoplasm of the stomach, then he
Yes.
doesn't have to put a differential there. See, if you are trying to make a histological diagnosis or a clinical diagnosis, then the question of differential comes. But if you are not making a histological diagnosis, then the question of differential does not arise. So you have to see what fits in your history and examination, and that is capped. If it does not fit in your history and examination, you keep it up. And if examiner asks, yes, definitely you have to tell him that what else it could be. You have to answer the examiner's question, but Mainak, you have to remember what I told you. Answer only wild guess is allowed, because wild guess means the examiner will go in that direction. So in the examination, you have to lead the examiner. You have to lead the examiner to areas which you know, not lead him or her away to areas where you know nothing. That is important part of being examined. You have to tell the examiner where you want him to go.